It's a pleasure to be with you. The title of this talk is Indicators and Measurement of Global Health, Part 1. There are no disclosures for this presentation. Objectives include review the definitions of ratios, rates, proportions, morbidity, mortality, incidence, and prevalence, review the uses of health data, discuss how cultural beliefs and values impact health behaviors, review the 5 major health status indicators and how they relate to global health, review 2 major burden of disease measurement tools, HALE and DALYs. Parts 1 and 2 of this session will focus on key indicators of health, the measurement of the global burden of disease, and demographic and epidemiologic transitions. As you will see, these topics are closely interrelated. Let's review a few common definitions used in global health data, including rate, ratio, proportion, morbidity, mortality, incidence, and prevalence. A ratio is the relative magnitude of 2 quantities, or a comparison of any 2 values. The numerator and denominator of the formula need not be related. Therefore, one could compare apples with oranges or apples with the number of physician visits. A rate is a measure of the frequency with which an event occurs in a defined population over a specified period of time. Because rates put disease frequency in the perspective of the size of the population, rates are particularly useful for comparing disease frequency in different locations at different times or among different groups of persons with potentially different sized populations. A rate is a measure of risk. A proportion is the comparison of a part to the whole. It is a type of ratio in which the numerator is included in the denominator. You might use a proportion to describe what fraction of clinic patients tested positive for HIV, or what percentage of a population is younger than 25 years of age. A proportion may be expressed as a decimal, a fraction, or a percentage. The 2 most common outcome measures are morbidity and mortality. Morbidity is the number of illness-related measures associated with a disease or health issue. Mortality is the number of deaths due to certain risk factors and diseases. Incidence rate is defined as new cases during a period of time per population at risk multiplied by a multiplier, often 100,000. These are new disease cases, conditions, deaths, etc., in a defined period of time in a specified population, the population at risk. Population at risk means those capable of developing the disease or condition. Incidence is a rate since it is related to a period of time. Incidence rates are important in studying causation, like exposures affecting health outcomes. Incidence rates provide information about the probability of someone in the population at risk developing a disease, condition, death, etc. during a specified period. As previously mentioned, rate is a measure of risk. Prevalence is defined as the number of existing cases in a population at risk at a designated time. There are several types of prevalence, including point prevalence, or cases at one point in time, for example, as of today. Period prevalence, would be the number of cases present in a population within a parameter of time, for example, a particular month, year, etc. Lifetime prevalence is the number of cases present during a whole lifespan. It's critical that we use data and evidence to understand and address key global health issues. Population health data is broadly defined as information related to the health outcomes of specific groups of people, namely nations, communities, or ethnic groups. Health data falls primarily into three categories. One, the health status of people and communities. This category would include data on life expectancy, child and infant mortality, etc. Two, health services. This category would include data on the number of nurses and doctors, healthcare coverage, etc. Three, financing of health. This category would include data on the public's expenditures on health, the percent of national income spent on health, etc. Health data is used in several ways. It identifies the presence of health conditions in populations. It quantifies the extent to which these health conditions impact people. It determines where and when conditions occur. This information is the heart of health surveillance systems and tools. It also provides valuable information about societal cultural values that informs plans and programs like community engagement to effectively address those issues. Understanding cultural health values is essential for program planners and particularly community engagement specialists. This is a diagram of culture adapted from J. Linwood Barney. The behaviors human beings manifest are dependent on deeper layers of culture as diagrammed. The worldview, or deep beliefs, are located at the center of culture. Those deep beliefs generally fall into four broad categories: beliefs about self as a human being, beliefs about nature, the supernatural, and time, the past, present, and future. Those deep beliefs or worldview set the base for a culture's values, or the things a culture deems important. It's upon those deep beliefs and values that a culture builds its institutions. These institutions include the way a culture governs itself, educates children, marries people, judges right and wrong, organizes and runs its businesses, addresses health issues, etc. Finally, those beliefs, values, and institutions influence and dictate the behaviors individuals of a culture manifest. Health-related values are expressed as the health priorities of a population group. These priorities are also referred to as the perceived needs of a community or group. These perceived needs may or may not reflect the real needs as perceived by a community engagement facilitator or other external experts. Yet these perceived needs are the health issues the community or group feels are important, the issues they will own and invest their time and resources in. From my experience, engaged communities will eventually address the needs perceived by external experts, but within their priority and time frame, not necessarily the external experts' time frame. This approach will often challenge a community engagement facilitator who would prioritize needs differently. True community engagement is facilitating a process of problem solving, not a project, and requires patience to move at the pace of the community. Community engagement concepts are covered in more detail in other sessions and courses of the North Dakota Public Health Training Network. Health data also provides health status indicators, providing tools to compare the relative health of population groups within countries and globally. This slide lists 5 key global health status indicators. The infant mortality rate, IMR, the number of deaths of infants under age 1 per 1,000 live births in a given year. The neonatal mortality rate, NMR, the number of deaths to infants under 28 days of age in a given year per 1,000 live births in that year. The under 5 mortality rate or child mortality rate, CMR, the probability that a newborn baby will die before reaching age 5 expressed as a number per 1,000 live births. The life expectancy at birth, LEB, the average number of years a newborn baby could expect to live if current mortality trends were to continue for the rest of the newborn's life. The maternal mortality ratio, MMR, the number of women who die as a result of pregnancy and childbirth complications per 100,000 live births in a given year. The infant mortality rate, neonatal mortality rate, and under 5 mortality rate or child mortality rate are all powerful indicators of a country's health, but largely dependent on the income status of the country. Most children who die under 1 year of age usually die in the first 28 days of life during the neonatal period and would be measured by the neonatal mortality rate. As an infant mortality rate declines in a country, the under 5 mortality rate or child mortality rate becomes a more important health indicator to follow. The life expectancy at birth is one of the most commonly used indicators of health status. Generally, the higher the life expectancy at birth, the better a country's health status. Seeing that the maternal mortality ratio measures the relatively rare occurrence of death associated with childbirth, it's measured per 100,000 live births per year versus 1,000 as with the IMR, NMR, or CMR. The maternal mortality ratio is quite difficult to measure due to its relative rarity and that these deaths occur primarily in low-income settings, having less resources available to monitor this indicator. So as with IMR, NMR, and CMR, maternal mortality is strongly correlated with a country's income or economic status. During this session, we will spend significant time talking about the 6 World Health Organization regions as depicted on this map, including the African region, Americas, East Mediterranean, European, Southeast Asia, and the Western Pacific regions. Let's look at the 2018 infant mortality rates globally via the 6 World Health Organization regions. The global rate was 28.91 per 1,000 live births. Africa had the highest rate of 51.82, followed by the Eastern Mediterranean region at 37.15, Southeast Asia at 27.6, the Americas at 11.54, the Western Pacific at 9.81, and Europe at 7.47. So Africa and the Eastern Mediterranean are regions above the global average. This graph shows the trends in IMR from 1998 to 2018. Global health strategies have obviously been working, with declines noted in all regions globally. The Western Pacific region bypassed the Americas between 2008 and 2013. In 2018, the neonatal mortality rates were highest in Africa at 27.16, followed by the Eastern Mediterranean at 25.85, Southeast Asia at 20.16, the Americas at 7.44, Western Pacific at 5.85, and Europe at 4.55. The global rate was 17.72 per 1,000 live births. Africa, the Eastern Mediterranean, and Southeast Asia are regions above the global average for the neonatal mortality rate. This graph shows the trends in neonatal mortality rates from 1998 to 2018. Similar to the IMR, there have been declines noted in all regions globally. As with IMR, the Western Pacific region bypassed the Americas trend somewhere between 2008 and 2013. The slope of decline in Southeast Asia is fairly marked compared with other trend lines. In 2018, the child mortality rates were highest in Africa at 70.25, followed by the Eastern Mediterranean at 43.54, Southeast Asia at 33.27, the Americas at 12.13, Western Pacific at 10.78, and Europe at 7.71. The global rate was 17.72 per 1,000 live births. Africa and the Eastern Mediterranean regions are above the global average. This graph shows the trends in child mortality rates from 1998 to 2018. Similar to the other trends, there have been declines noted in all regions globally. The Western Pacific region, once again, as with the IMR and the NMR, bypassed the Americas trend in child mortality rates. The slope of decline in Africa is fairly marked, particularly between 1998 and 2013, compared with other trend lines. Life expectancy at birth is the average number of years that a newborn is expected to live if current mortality rates in the population continue to apply. It can be calculated for people at any age, but is usually reported as life expectancy at birth. Let's now briefly discuss the life expectancy at birth. Though the calculation of this indicator is beyond the scope of this session, the basic formula is listed here, where Li stands for life expectancy at birth, Xi and Xi minus 1 are the ending and starting points of each interval of life to be calculated. Pi equals the percentage of total population that lives on to the I plus 1 interval. Ai equals the average number of years lived in an interval by an individual who passes away in the same interval, and Di equals the percentage of total population that dies in the interval x1 minus 1 to xi. This is an example of the World Health Organization's life expectancy at birth for 19 countries in 2016. The global average was 72.77 years, the gold line. As previously mentioned, the higher the life expectancy at birth, the higher the country's health status. Countries with the lowest life expectancy at birth for these 19 countries, indicating a lower level of health status, include the Central African Republic, Ghana, Haiti, and South Africa. Countries with the highest life expectancy at birth on this graph, indicating a higher level of health status, include Singapore, Australia, Denmark, and Germany. The United States, indicated by the yellow arrow, is above the global average for life expectancy at birth at 78.5 years, but is not even in the top 5 of this list. This table shows the life expectancy at birth by gender for those same 19 countries sorted by female values, largest to smallest. In all of these countries, females lived longer than males. The average difference in life expectancy at birth in 2016 was 5.083 years, with females averaging 75.1045 years and males 70.6215 years from birth. This demonstrates the global gender disparity for life expectancy. This graph shows the percent of gross domestic product, GDP, spent on healthcare for 6 countries: Austria, Canada, Germany, Switzerland, the United Kingdom, and the United States. The United States spends far more on healthcare, but has a lower health status per life expectancy at birth data than the other 5 developed countries on this graph. These tables are dramatic examples of the disparity of maternal mortality ratios for 15 high-income versus 15 low-income countries. Global health often refers to individuals or countries as low, lower middle, upper middle, or high income. This table from the World Bank defines these 4 income groups. In the low income group, a person earns an annual income of less than or equal to $825 per year. The lower middle income group earns between $826 and $3,255. The upper middle income group earns from $3,256 to $10,065, and the high income group earns $10,066 or more dollars annually. Notice that the average maternal mortality ratio of the 15 high-income countries is 7.4 per 100,000 live births versus 536.33 for the 15 low-income countries, demonstrating the strong correlation between these ratios and a country's economic status. We've discussed several key global health indicators and their trends. Let's now discuss the measurement of global burden of disease. There are 2 major tools used to measure global burden of disease: the Health Adjusted Life Expectancy, or HALE, and the Disability Adjusted Life Year, or DALY. These tools take into account morbidity, mortality, and disability. They allow the comparison of health status between WHO regions, countries, and within countries. Burden of disease analysis combines health data from many sources and evidence from epidemiological studies to create summary measures that incorporate both the prevalence of a given disease or risk factor and the relative harm it causes. The measures allow decision makers to compare the relative effects of different diseases or outcomes associated with risk factors, such as smoking-related diseases versus diet-related diseases, and then use that information for health policy development, planning, and evaluation. Health Adjusted Life Expectancy, HALE, pronounced HALE, is life expectancy adjusted for disease and disability. HALE is the average number of years that a person can expect to live in full health by taking into account years lived in less than full health due to disease and or injury. It captures both fatal and non-fatal health outcomes in a summary measure of average levels of population health. This is a somewhat complex computation, but simplistically, HALE equals the life expectancy at birth of a population or country minus the average of the less than full health years for the group, based on the expected health impact of disease and injury. For example, as diagrammed in the pie graph, if the life expectancy at birth for a group or country is 80 years and the average of the less than full health years is 28 years, then the average full health years, or HALE, would be 52 years. The health-adjusted life expectancy measure, or HALE, is best described by a quote from the World Health Organization. The health-adjusted life expectancy is the equivalent number of years in full health that a newborn can expect to live based on current rates of ill health and mortality. This table shows the comparison of the life expectancy at birth, LEB, and the health-adjusted life expectancy, HALE, at birth for the 19 countries we've been considering. When adjusting or factoring in the impacts of illness and injury for males, the HALE averaged 8.225 years less than the LEB. These 8.225 years were the average years of less than full health over the expected lifespan of a country's citizens. Notice the order for males highlighted on this table, for example, China, followed by the US and Mexico, as indicated. This table shows the comparison of the LEB and the HALE for females. The HALE averaged 9.466 years less than the LEB. Once again, these 9.466 years were the average years of less than full health over the expected lifespan of a country's citizens. Also notice the order of the countries highlighted. For females, the order is US, Mexico, and China versus China, the US, and Mexico for males. There are also other male-female order differences between these 19 countries. The disability-adjusted life year, or DALY, was first used in 1993 in the World Development Report of the World Bank. A detailed discussion of how DALYs are calculated is beyond the scope of this session. A DALY is a health gap measure. DALY is a measure of overall disease burden expressed as the cumulative number of years lost due to ill health, disability, or early death. The formula for DALY equals YLD, or years lived with disability, plus YLL, or years of life lost. The DALY relies on an acceptance that the most appropriate measure of the effects of chronic illness is time, both time lost due to premature death and time spent disabled by disease. The sum of these DALYs across the population, or the burden of disease, can be thought of as a measurement of the gap between current health status and an ideal health situation where the entire population lives to an advanced age free of disease and disability. DALYs for a disease or health condition are calculated as the sum of the years lost due to disability, YLD, for people living with the health condition or its consequences, and the years of life lost, YLL, due to premature mortality in the population. The years of life lost, or YLL, basically corresponds to the number of deaths multiplied by the standard life expectancy at the age at which death occurs. The basic formula for YLL is the following for a given cause, age, and sex. YLL equals N times L, where N equals the number of deaths due to a disease, L equals standard life expectancy at age of death in years at the age at which death occurred due to this disease in the population. To estimate YLD for a particular cause in a particular time period, the number of incident cases I in that period is multiplied by the average duration of the disease L and a weight factor DW that reflects the severity of the disease on a scale from 0, perfect health, to 1, dead. The basic formula for YLD is incident YLD equals I times L times DW, where I equals number of incident cases, L equals average duration of the case until remission or death in years, DW equals disability weight. A prevalence YLD is based on prevalence rather than incidence. The formula for a precedence YLD is precedence YLD equals P times DW, where P equals the number of prevalent cases and DW equals the disability weight. The original Global Burden of Disease study and WHO updates for years 2000 to 2004 also applied several social value weights in the calculation of DALYs for diseases and injuries. Apart from the disability weights, these also included time discounting and age weights. For more information on the social value weights that are applied to the calculation of DALYs, please see the reference listed on this slide. When calculating DALYs, health conditions are generally divided into three categories. Group 1, communicable, maternal, and perinatal conditions occurring within the first week after birth, and nutritional disorders. Group 2, non-communicable diseases. Group 3, injuries like road traffic accidents, self-inflicted injuries, and violence. A country or group that has more DALYs in the three groups of health conditions listed is considered less healthy than others with less DALYs. A goal of health policy is to reduce the number of DALYs in the most cost-effective manner possible. DALYs and other composite indicators give a better estimate than measuring deaths alone of the true health of a population. DALYs are often used in global health planning processes, providing excellent measures of overall health status. Calculation of DALYs requires prevalence and incidence data that are not always readily available in resource-poor countries. Therefore, health expectancy measures to assess health status are still commonly used in developing countries versus DALYs. In summary, it's critical to accurately gather and use data to understand and address global health issues. Health data indicators provide tools to compare the relative health of population groups within countries and globally. DALYs and other composite indicators give a better estimate than measuring deaths alone of the true health of a population.
Take your public health practice skills to the next level. Our specialized certificate courses give you an opportunity to work systematically through a public health topic and demonstrate your understanding of that material in a capstone project. Learn more and sign up at ndphtn.com/certificates.